So it's a pleasure to first presentation of this session by Leonard Bikinesi. Leonard Bikinesi is the Chief HIV Clinical Mentor at the Ministry of Health and Social Services in Namibia. He is trained at Stellenbosch University, and his areas of interest include HIV drug resistance, clinical governance, telementoring. And today, Leonard will be presenting engaging in collaborative, hands-on learning, building the response in Africa. Thank you. Over to you, Leonard.
Good day. My name is Leonard Bikinesi. I'm a specialist family physician working as a chief clinical mentor for the Ministry of Health and Social Services in Namibia. First of all, I'd like to thank Interest 2020 virtual conference organizers for giving me this opportunity to talk to you about collaborative hands-on learning, building the response in Africa. Our continent, Africa, is the world's second largest and second most populous continent. Sadly and unfortunately, it is the poorest and least developed. When we look at the health issues affecting this continent, you'll find that it is the most affected by HIV. It also has challenges with other diseases such as TB and malaria. Over the past decade, Africa has seen a rise in the number of cases on non-communicable diseases. In addition to that, there is a chronic shortage of human resources across all health fields. Due to the vastness of this continent and coupled with limited resources, some of the distances that our clients have to travel are long, making it very difficult for them to access health services. One of the solutions to all this is through collaborative learning. The idea is to move knowledge to where it's needed. The ECHO model, which was launched in 2003 in the United States, has demonstrated that it is able to address some of the challenges that are found in Africa. ECHO, which stands for Extension for Community Healthcare Outcomes, is a guided practice model that reduces health disparities in underserved and remote areas. This model uses a hub and spoke knowledge sharing approach, where a team at the hub leads a virtual session, thereby amplifying the capacity for providers at the spokes to learn and share best practices. The ECHO model is based on 4 core principles. The first one is to do with leveraging of technology. It uses technology such as video conferencing to amplify scarce human resources. Second principle, case-based learning. Learning in an ECHO session is done through collaborative management of clinical cases or public health issues or problems with subject matter experts. The third principle is about sharing of best practices. Sharing of best practices improves outcomes by reducing variations in processes of care. And this is achieved in 2 ways: through brief didactic presentations, and secondly, through reinforcement of evidence-based guidelines. The fourth principle is about promotion of continuous quality improvement through monitoring and evaluation of outcomes. As you can see, that this model creates an interactive learning environment where there is collaboration at multiple levels. Participants are able to co-manage cases or public health issues with experts. They learn from doing, they learn from the didactic presentations, which are usually short, less than 20 minutes long, the approximate time where most adults' concentration span will start waning. They also learn from each other, and in so doing, they learn to collaborate when it comes to problem solving. So as you can see, this is like an ongoing mentorship. On the right side of the screen, you see the diagram showing that the result of all this is a dynamic loop, which is infinite, where all the teams can teach and all the teams can learn. In Africa, this model was first implemented in Namibia in 2015. The program was on HIV care and treatment, and it covered 10 sites with high HIV burden in the country. The ECHO model has been running in Namibia for the last 5 years, every week on Tuesdays. This model was implemented to address challenges not only unique to Namibia, but also found in other African countries, such as high HIV burden, lack of human resources, especially at the peripheral clinics, and long distances between clinics and referral sites. Following successful implementation, a post-pilot evaluation was conducted in 2017. The results showed that the model demonstrated improved knowledge of clinical HIV amongst all healthcare workers, but especially amongst the nurses. Healthcare workers also reported reduced professional isolation and improved CPD credit access. Over the years, this model, together with other interventions that the Ministry of Health and Social Services of Namibia has implemented, have significantly improved the HIV program. Some of the highlights include reduction of HIV referrals, management of complicated HIV drug resistance cases by registered nurses at peripheral clinics. Since the successful implementation of the ECHO model in Namibia, other African countries have successfully implemented this model with amazing results and innovation. This slide shows African countries with hubs. Even though not all countries have got hubs, some continue to participate in other ECHOs. This expansion has not only been on the number of sites or countries with hubs, but it has also been in terms of disease or topic area covered. From the first HIV care and treatment ECHO in 2015, you can see that it has expanded to cover more topics such as surveillance, outbreaks, safe surgery, cancer, emergency preparedness, autism, and in 2020, COVID-19 ECHO sessions. This slide shows an example of a multi-drug resistance TB ECHO that was launched in August 2016 in Kenya. This one is an example of collaboration of multiple African countries. This is an ECHO that was launched in December 2017 by the African Society of Laboratory Medicine. This is a monthly ECHO that connects 11 countries in Western and Southern Africa. Some of the countries that participate in this ECHO are Democratic Republic of Congo, Ethiopia, Kenya, Malawi, Tanzania, Zambia, and Zimbabwe. This one is an ECHO that is currently run by Africa CDC. This ECHO covers topics to deal with disease outbreak. On this slide, you can see a session in progress discussing outbreak reports on cholera, monkeypox, outbreak surveillance in Congo, and antimicrobial resistance in Zambia. This slide shows 9 African countries that are taking part in the Infection Control Africa Network ECHO. This ECHO was launched in 2018 to share best practices in infection control prevention. Countries which participate in this ECHO include Kenya, Cameroon, South Africa, Sierra Leone, Togo, Tunisia, and Zimbabwe. As you can see in the last few slides, the model has not only expanded in terms of the number of countries that are doing it, but it has also expanded in its scope. Some of the innovations include the collaboration between different African countries. Now let me talk briefly about how this model has been used during the COVID-19 pandemic. When COVID-19 hit Africa, it immediately exposed several gaps in our health systems. These gaps include increased inaccessibility of health services, and this was as a result of a restriction in movement in most regions, which came about due to the lockdowns that were initially put in place earlier on in the pandemic. It also exposed the shortage of specialists or experts that we have in Africa, especially in the field of infectious disease, high and intensive care units, and pulmonologists. There was also a growing demand for training, as most of the healthcare workers had inadequate knowledge on subjects such as infection prevention control, triaging, and high care. Some of our healthcare workers, unfortunately, were exposed to COVID-19, so they had to go into quarantine. And this further worsened the number of human resources on the ground. So the ECHO model was used to bridge some of the gaps that COVID-19 had created. Using knowledge and lessons learned in using ECHO in other diseases, countries could leverage on the model to address the COVID-19 situation. The model was used to build capacity of healthcare workers and also community-based workers. The scope of topics that were done included training on COVID-19 case management, surveillance, laboratory, IPC for both healthcare workers and for patients, and also addressing issues to do with continuity of care during COVID-19. These slides just highlight some of the results of the implementation of this model during COVID-19. Of the already existing 22 hubs, they were able to run 28 COVID-19 ECHO programs. 10 new ECHO hubs were created or started in Africa as of September 2020. And since March, nearly 55,000 healthcare workers have attended ECHO COVID-19 sessions in Africa. And this translates to more than 75,000 learning hours over 200 sessions. And the beauty of all this is that there was no interruption of work. Some of the experience from my colleagues in South Africa shows that some of the experts and specialists, even when they were in quarantine, they were still able to join the session and share treatment recommendations for patients that were admitted. So looking ahead, ECHO can be implemented in several key areas. Three of them that quickly come to my mind are things to do with COVID-19 vaccine administering. The enormity of the task will require innovative thinking. It will not only about the clinical aspect of it, perhaps the reporting of adverse events, but there will also be a need to disseminate correct information to the community about the vaccine. When it comes to maternal and child health programs, a lot has been done in improving maternal and child outcomes. However, there are several gaps that remain, such as elimination of mother-to-child transmission of HIV and reducing of maternal mortality. The other thing that comes to my mind, and that is dear to me as well, is improving pediatric HIV outcomes. Pediatric care is lagging behind adult care. Viral load suppression rates in children are much lower compared to adults in most African countries. In addition to that, there's a shortage of pediatricians and experts in this field. There's also a need to strengthen collaborations to bridge gaps and to standardize care across African countries. I'm thinking of an example of an outbreak that involves several neighboring countries. For example, an Ebola outbreak. The model could be used to coordinate efforts, share best practices, and also brainstorm on some of the issues that will most likely be similar among the countries involved. Ultimately, whatever we do, be it reaching the community or collaborative research and publication development, the thing is, the few resources we have in Africa, we need to amplify them to get better clinical and public health outcomes. We can do so through collaborative learning using models such as the ECHO. I'd like to take this opportunity to thank the Ministry of Health and Social Services of Namibia, as well as the ECHO Institute for this model, and PEPFAR for funding this program in Namibia, and of course I know also in other African countries. Thank you very much.